Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, your host, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, make sure you're in a quiet room when you call, with your TV turned all the way down so that we can hear your question. That number to call is 318-219-4569. Today's topic is diagnosis and treatment of breast cancer. And joining me today to talk about this is Dr. Julie Cupp, a breast surgeon with Willis Knighton Breast Surgery, Piermont. Thanks for joining us.
Happy to be here. Thank you.
Absolutely. So breast cancer is one of the most common types of cancer for women, correct?
It is the second most common type after skin cancer. Gotcha.
Okay. And so this is something that you definitely specialize in.
Yes.
And we're going to talk a lot about the treatment options and maybe things to look for. You know, if someone at home is wondering, maybe do I have breast cancer, or how do I prevent my risk?
Yes.
Okay. And so are there several different types of breast cancer?
So there's many different types of breast cancer. There's ductal, lobular are the most two common types, and that's talking about what part of the breast is it coming from. Is it coming from the milk ducts or from the glands that make the milk? Ductals are the most common, but when people talk about different types of breast cancers, they're usually referring to the receptors, and they talk about hormone-driven breast cancers or triple negatives and things like that. So we have three different receptors that we look at. We look at the estrogen receptor, the progesterone receptor, and a protein called HER2. And so each of those can either be positive or negative. And the reasons we focus in on these different receptors is because they can guide our medical treatment for breast cancer. So if we have one that is driven by estrogen, then we use medicines that block estrogen from getting to the breast cells in order to reduce the risk of recurrence in the future.
Gotcha.
Whereas if we have somebody who has too many copies of the HER2 protein, we have drugs that block that protein in order to decrease the overexpression, and has really changed the game for HER2 positive breast cancers.
Okay. And so what type do you typically see the most in your clinic?
The most common is hormone receptor positive HER2 negative. That encompasses 80% of all breast cancers.
Okay. And so let's say you have a family history, and you know, how do you know if it is true family history, or maybe, you know, your grandma just happened to have it because of lifestyle?
So that can be really hard to determine. There's a lot of different factors we look at, most specifically how old were they whenever they were diagnosed. The younger they are, the more of a risk that it could be a genetic mutation and something that's going on in the family. If we have an isolated person, especially in the postmenopausal age, the likelihood of it being related to genetics is less likely, and it's more likely just because she's female, has breast, and she's getting older.
Okay.
Those are the top factors. But if we see certain patterns though, so it's grandma, two of her sisters, you know, another, her daughter, you know, your aunt kind of thing, all of this, and we see lots of it in multiple generations, that's when we start really thinking, could there be a genetic mutation? So also, if there's a family history of men with breast cancer, that's a big red flag for potentials for genetic mutations.
Oh, gotcha. Okay. And so if someone knows that they have these types of things in their family, and maybe they're young and they don't have breast cancer yet, what steps should they take?
So the big thing is talking with their primary care physician, gynecologist, or with a specialist myself, to figure out where does their risk actually lie. You know, is it actually elevated above 20%, which is what we call high risk, or is it just elevated because there is some family history? Once we get a sense of, does this look like the potential for genetic mutation versus just, yeah, there is a little bit of family history, we can start figuring out whether or not they need genetic testing, or if they need modified schedules for screening. If they are eligible for genetic testing, we talk about, you know, what are the possible answers, which are positive, negative, but also maybes. Because genetics is a really new field, so we don't know everything about all these mutations we see, and so we have some of them that just fall in this we don't know category, and that's also just as much anxiety invoking as not knowing what your status is altogether.
Right.
And so, but fortunately, most of those maybes turn out to be negatives. So we really don't worry about them. We treat them as if they're negative unless they're ever proven positive. One thing I do caution, though, is anybody who's considering doing genetic testing is to make sure that they have life insurance and disability insurance in place before they get testing. Because if they do the testing and are found to be positive for a mutation, that's now a pre-existing condition for life and disability insurance.
Wow.
And so you want to make sure that your financial house is in order before you try to do that, because it could have major implications financially later on. Because if you are young, have young children at home, and you're diagnosed with something like breast cancer, and your insurances don't cover it, that disability insurance is not going to be there to help pay the bills.
Yeah.
And if, unfortunately, some people do die of breast cancer still, and they leave behind small children, and they don't have enough of a life insurance policy to cover their medical expenses and to replace what they provided for their family, even if they were a stay-at-home mom, you'd have to replace childcare, transportation, everything that mom was doing before she was gone. So we want to make sure that that's in place. So I really don't like having my 18-year-olds coming in going, I need genetic testing now, because I can do all the high-risk screening that they need without knowing their genetic status, just because they're guilty by association with their family history. So I'd rather wait until they're older, they're settled in their jobs, they have their insurance in place, and then when we start thinking about doing things we can't take back, like risk reduction surgery, then let's find out if they actually even need that.
Right. Yeah, that's really good advice. Yeah, so thanks for sharing that. And I'm sure that that's very impactful for some people. And like you said, just move on with your life and then, get settled. That's really, really good life advice. Okay. So self-exams, self-breast exams, is this something that people should be doing at home?
So the guidelines have gotten away from saying self-exams because a lot of people get really anxious at the idea of, I don't know what I'm feeling. What really and truly, they started calling it self-awareness, which resonates better with people. And really and truly, we just want to know, do you feel something that's changing from your normal? I do this every day, and my fingertips are not any more magical than yours. And I don't know what I'm feeling any better than anybody else, other than, does this feel different than the rest of the breast? And so from there, we can go, hey, we feel something that's different. Let's get a mammogram. Let's get an ultrasound. We may even need an MRI to try to figure out what's going on. But by paying attention and getting to know how things normally feel, if something's changing, you can bring it to us and we can investigate what it is.
Yeah, and that's a good point too. Knowing your body, you know your body best, and then what, if something is evolving, then that might be of concern.
Exactly. And a lot of times these are even just benign changes that we're feeling, that's just a fibroadenoma or a breast cyst or something like that, and it's simple and it's not life-threatening in any way, shape, or form. But it is something that's different. And so we check it out, we make sure it's okay. In some cases, we even still remove the lump that's there just because it's growing and causing a deformity. But it doesn't automatically mean something's bad just because you feel something.
Yeah, right. Okay. And so you're a breast surgeon, and this is a treatment option, right, for someone that maybe has a lump, or it could be benign, it could be just there, and not cancerous, which is great. But you can also remove it as well if it is cancerous.
Yeah, I do operate on people who don't have cancer to remove lumps and bumps and things like that in order to, especially like my young women who have fibroadenomas, which is like a clump of breast tissue. And it's growing and it's starting to cause a deformity in that breast. And so we take it out so that a way their breast looks natural. Or if we have one that's causing a lot of pain, a big cyst, we can aspirate the fluid out of the cyst and the pain's gone. So there's plenty of reasons why we do it. And sometimes I even do it just to relieve anxiety, especially if there's a strong family history. just knowing for sure it's not and having it out just brings so much peace of mind and everything to the patient. And I'm happy to operate.
Absolutely. Okay. And so if you do find maybe the fibroadenoma, which is, I guess, benign.
Yes.
Mass.
Yes.
And that doesn't necessarily mean you're at greater risk for cancer either?
It doesn't. It's just somehow or another that breast tissue kind of clumped up into a collection, and it's just benign stuff. So benign things don't increase the risk of cancer in the future. However, if we ever did a biopsy and we found some abnormal cells, kind of like if you do a pap smear and it comes back with atypia, then that does increase the risk of breast cancer in the future.
Okay, and so I assume that a lot of people may get nervous about surgery, or maybe they are diagnosed with cancer and they're considering a double mastectomy. How often maybe are you required or to have that kind of surgery?
So the choice for surgery, the big main factor on what we have to do is how big is the cancer versus how big is the breast. So if you have a 2-centimeter tumor in somebody who's barely got an A-cup breast, they're potentially going to be more likely to need a mastectomy compared to a lumpectomy because they don't have enough breast tissue for it to still look normal after surgery. But the same 2-centimeter tumor in somebody who's got a triple D, that's easy.
Right.
So it really depends on that. Or if someone has multiple areas of cancer versus just one mass, that may require mastectomy just because, again, the breast would not look normal after the lumpectomy because it's too big of an area or in too many different locations.
Right.
So for the most part, most people actually don't have to have mastectomies. A lot of people do choose to do mastectomies, and that can be for many reasons. Some peace of mind, some because of when we do a lumpectomy, there is a higher risk that we would have what's called a positive margin, meaning the cancer comes up and touches the cut edges or comes too close to where I cut. And so in order to make sure that there's nothing on the other side, we would have to go back and do another surgery. And so they want to minimize the number of surgeries they could potentially need, so they choose that. Sometimes because they have to have the mastectomy kind of thing. Others is because they don't want to do radiation, and people who have mastectomies are much less likely to require a course of radiation afterwards compared to those who have lumpectomies. They do require radiation afterwards.
Oh, okay. Yeah, so it's a really individualized.
It's extremely individualized. I have a lot of people come in and go, well, what do most people do in my situation? And I'm like,
that's a loaded question.
That's a really hard question to answer because it really depends on the person and the situation they're in. Some people, especially really young women, they're like, yes, I just want this all done. I want to minimize my chances of something happening again. I'm too busy with the kids and everything else in my life to do this. So they opt for a much bigger surgery and then potentially even removing the other breast. Whereas somebody who's 75 years old is like, yeah, I'm good with just doing as little as possible because I don't want a hard recovery, things like that. And so it really just depends on where that person is in their life and what level of risk they're willing to take.
Yeah, makes sense. Well, we have a caller on the line.
Yes.
Kay, thanks for joining us. And what is your question for Dr. Cupp?
Yes, good afternoon. I was born pretty much small-breasted, and I had 2 children at age 19 and 21, and I developed lymphedema in my lower extremities at a young age, and in my 30s I had implants in the breast for cosmetic, reasons. I'm nearly 70 years old now, and I've had these breast implants all these years. But I had an abscess under my right arm that they went recently, and it was a nurse practitioner.
Okay.
And I do have mammograms, But do I need to be concerned about anything going on there with that that was under my armpit?
I doubt that there would be any relationship between you having the implants that are a little bit more mature in time frames and the abscess that you got. Most abscesses that we see underneath the arm are more related to skin issues. And so it's very unlikely to have affected your implant or to be caused by the implant.
Okay, having had the implant for so long, what is your recommendation on that?
So, according to the FDA, they really say that implants should be changed every 10 years. And in my practice, I would say that most people don't do that. So, unless the implants are causing people problems, such as capsular contraction, where the capsule that forms around the implant becomes very firm and hard and is causing pain and things like that, or if they have a saline implant that leaks and it goes flat on that side, most people really don't electively go back to surgery every 10 years to get it done. The only time that it really has to happen is if it's causing complications, such as you've got one that's flat on one side or causing pain with capsular contraction and things like that. Or if we're worried about a type of breast, or it's not actually a breast cancer, but a lymphoma that's associated with implants that can be due to very old and highly textured implants, and it's called lymphoma or breast implant associated lymphoma. It's kind of out of my wheelhouse. Usually plastic surgeons are the ones who take care of that. And signs of that is typically an unprovoked swelling in the breast and fluid collection around the implant. Now, fortunately, it's really easy to treat type of cancer if it were to happen. And usually the treatment is take out the implant, take out the capsule, and sometimes we can even just put a new implant in its place right afterwards. And that's what most people have done for their treatment for these implant-associated lymphomas. Very few of them need any other type of treatment, such as chemotherapy or anything to that nature.
Well, thank you. I did get scheduled mammograms. I guess they would show up anything that...
Yes, mammograms are the most important part.
Fortunately, the shape of them haven't really... I mean, they've changed some, but, but they're not... I mean, they're still good.
Well, good. I'm glad.
but I do worry about. I do get a little concerned about the abscess, and the lymphedema problems that I already have,
Definitely understand.
All right, thanks, Kay, for joining us. And
well,
if you're just joining
thank
us,
you.
Yeah, if you're just joining us, give us a call at 318-219-4569. We're talking about breast surgery, and we've got breast surgeon here, Dr. Julie Cupp, and we're answering all these questions. And so we previously were talking about, surgery, like a lumpectomy or a mastectomy, double mastectomy, whatever the case may be, or what patients need. So how long does the recovery last, and maybe according to each type of surgery that you're doing?
So with a lumpectomy, just because we're taking a small section of the breast, most people I find are back to work about a week after surgery. So it's a really well tolerated surgery. Most people, the biggest thing that worries people is pain afterwards. And actually with breast surgery, the pain is not really as bad as what people think it's going to be. We compare it to people who've had belly surgeries or back surgery where we're messing with bone and things like that. And those surgeries hurt. They really do, because like with belly surgery, every time you breathe, sneeze, cough, you're pulling on that incision, and so it hurts a lot. Whereas with breast surgery, this is not a mobile area. So for the most part, unless you're having like direct contact, so like please don't hug me hard kind of thing, there's really not a lot of pain with it. There's discomfort, it's sore, it's tender. Again, like let's hug from the side, not direct frontal kind of thing. So patients actually really tolerate it extremely well. And most people take pain medicine, I find, like the first day, maybe the second, and then they're like, it's really not hurting me. And so Tylenol, ibuprofen, and ice packs are girls' best friends as far as recovery from a pain standpoint. The other risk of complications are very, very minimal as far as infection or wound healing issues or anything like that. So people do really, really well. And the same thing actually is true for mastectomy, but because there's drains involved after mastectomies, recovery is a little bit longer, and usually most people don't like to go back until the drains are out.
Gotcha.
Now, I do have some people who get a little stir crazy at home and are like, I just have a desk job, can I please go back? And I'm like, sure, that's all we're doing at home anyway, so
Right.
it's easy. But I do let them understand that, you know, they may not have the normal energy level, and so a full day at work might be a little bit overwhelming if they go back too soon. When it comes to reconstruction, and we're doing implant type reconstructions, or if someone goes out into the surrounding regions and has tissue-based reconstructions, then recovery is a bit longer. Most people are out for at least 6 weeks, sometimes up to 8 weeks, depending on the type of reconstruction, how long drains need to stay in, and things like that.
Gotcha. Okay, and the drains, that's probably individualized too, or do you?
So anybody who's had a mastectomy is going to have at least one drain on each side that's done. So if they have one breast removed, there'll be one drain. Sometimes there are need for more than one drains, especially with reconstruction. We sometimes have 2 of them in on one side, but each side will each have at least one drain, kind of thing.
Gotcha. And then, so that's before maybe going back to work. Now, what about like activity or walking or anything like that?
So from an activity standpoint, my biggest restrictions are trying not to get too sweaty.
Okay.
And the summer, you know, that's kind of hard. But, you know, I want them to, you know, get up, moving, going for a walk is great. I don't want people like heading right back out to the gym the next day, just because things are a little bit too sore, and all that jostling could lead to some bleeding, and we don't want big bruising in the breast or anything like that. So usually I tell them to take like a week off from the gym, and then after that ease back into it and just kind of feel their way out and see what they can tolerate or not tolerate. But normal activities of daily living that are necessary, they can do from day one. You can clean yourself, you can carry your own plate to the table, things like that, but it's not the time to worry about vacuuming and cleaning the baseboards and entertaining everybody, because you are recovering, and so you need to take it easy, lay low, relax, take a nap if you need to, but you can still get out and go to dinner one night, or maybe go to the grocery store because the walls of the house are getting a little too close to you and you need to get out for a bit.
Well, good advice. Good advice. Well, we have Terry on the line. Terry, thanks for joining us. And what is your question?
I had a mammogram a while back, and on the x-rays it showed some kind of mass inside of one breast. And so I had to have a biopsy, and the biopsy confirmed that it was not cancer.
Okay.
And 6 months later, I had another mammogram, and it confirmed that I did not have cancer. But I don't really understand the mass. You know, what kind of, I don't know if it's a calcium mass or what grows inside of your breast.
So there's a lot of different things that could be. Without seeing the actual images and reading the reports, I couldn't comment specifically on your case. But many things that we can see whenever we see a mammogram, do a biopsy, and it's benign. It can be things like a papilloma, a fibroadenoma, a cyst, a hamartoma. There's lots of different benign things that happen in people's breast. A lot of that all just falls underneath the category of benign fibrocystic changes. And so they aren't anything to worry about as long as they did not see any atypical cells in there, and obviously if they didn't see any malignancy. And usually when they do the 6-month follow-up images, it's to make sure that it's stable and hasn't shown growth during that interval, because even though it's benign, some things still decide to grow, and if we see growth, then we're going to recommend taking it out. So if your follow-up mammogram showed everything was nice and stable, then yay.
All right, Terry. Well, thanks for joining us. And that's a great question. You know, you definitely want to know what's going on with your body. And there are several tests to determine breast cancer. I mean, obviously, a mammogram. Any others that may be less common that other people can, if they're, I don't know, if there's another one that's good, like the mammogram?
So the gold standard for screening is definitely mammogram. So that's the thing that we're not replacing. So if you're looking like, what can I do instead? That's definitely what has to happen. Gotcha. Okay. Other things that we've heard talked about is ultrasound. So ultrasounds are really good at characterizing if something is solid versus cystic. So if we feel something specific or we saw something on a mammogram, it's really good about giving us the details of it. So if it's a cyst, yay, most of the time that's benign and we don't need to be worried about it. If it's solid, depending on its shape and how it looks on that ultrasound, will give us a level of concern whether it's benign versus a cancer kind of thing. There is a lot of discussion about using ultrasound as a screening tool where they just ultrasound the entire breast. That is not the best way at this point in time to screen, because ultrasound is very user dependent. And so if you don't have somebody who's really good and is looking at every single bit of the breast tissue in a very uniform fashion, you can miss things very easily. And I've seen people think something's bad that is actually completely normal just because they don't know what they're looking at. And it's nothing against my ultrasound techs out there. It's just breast ultrasound is a specific certification and it's very hard to do. And so volume matters in doing it. And so if you're doing it every day, you get better at it. But even for my breast ultrasound techs who are specialty trained in it, it's very dynamic, and so you can't really control it the way you can with mammogram. It's very standard pictures that are done each time, so you can reproduce it very easily. So ultrasounds are just not quite there yet. Now we are developing technology, what's called automated breast ultrasound, where they basically put this huge probe over the breast and it scans it in a very uniform fashion. It takes the user out of it basically and gets more standardized, but that is still very early in development, and our radiologists have to get better at knowing how to read those and interpret and everything else to make sure that they're as accurate as possible. Another adjunct for screening and even diagnostics is MRI. So breast MRI is another one that we can use for it. That is really good for people who we feel something but we can't see anything on mammogram or ultrasound, and so we want to just a little bit more look into it. Some people who have high breast density, especially if they have a high risk of breast cancer at baseline, or people who just have high risk of breast cancer due to family history or other factors, including genetic mutations. And then we do routinely alternate between mammograms and MRIs. So every 6 months, we're doing some kind of picture, but the MRI does not replace the mammogram.
Yeah. Okay. And we did have a caller on the line. Is Tina still with us?
Yes.
Okay. Hi, Tina. What's your question?
I have a question. If a primary care doctor referred me over to a specialist, and I have 2 aunts and a sister that just got, 2 aunts that had breast cancer and passed away, and my sister just got diagnosed this summer. And the primary care doctor referred me to a specialist, but I didn't have any images done yet.
That's quite
when
okay.
The images come, and then when the images come in, if they're ordered by my primary care doctor, does the specialist have to order it also?
No, if there's images already done by the time you get there, we don't need to repeat them. Usually we can get a copy of them if we're not in the same system. However, if you get the referral and you get the appointment before you get your mammogram done, that's no problem. We'll make sure that you get your mammogram done and coordinate any follow-ups according to the results of that imaging.
Okay, so if the results just come back like a simple cyst, then normally you guys wouldn't follow up with that?
Yeah, usually if it's simple cyst, things like that, that's considered benign, and we just continue with routine screening.
All right, thanks Tina for your question. And we've got just about 90 seconds left, so if anybody is out there wanting to work with you or maybe be referred to you, do they need a primary care for referral, or can they just call your office?
They can just call my office. There's no need to have a referral. I accept pretty much all insurances and happy to help whoever I can.
All right, and the website and that phone number is right there on your screen. And yeah, this is Breast Health and Surgical Specialist.com, and you can get in touch with your team.
Yes.
All right, and you accept most insurances and specialize kind of in maybe the whole gamut, the prevention, maybe detection, and then the treatment as well.
That's what I do.
All right, well thank you, Dr. Cupp. This was very informative. I still have like several questions, and I didn't even get to half of them, so maybe we'll continue answering these sometime soon. But thanks for joining us. And if you missed this, and if you're just joining us, or if you want to rewatch this, you can just go to our website at ktbs.com/Healthline3 podcast, and you can rewatch us and get all that information there. Thanks for joining us, and we hope you have a wonderful Thursday.